What do you get when you combine a world-class EMS physician and medical director?
I speak pretty good English for a guy from Detroit.
With an EMS veteran and all-around nice guy.
Well, that's the dumbest thing I've ever heard.
Oh, that's so good. Oh, my God.
Well, you get the EMS Show. Taking it to the people, here's your host, Dr. Ritu Sani and Mike Vercast.
Hey, everybody. Welcome to the EMS Show. Mike Vercast, Dr. Ritu Sani, back with you again. And if you've been hanging out with us for a few years, you might know this guy down here. Yeah. Yeah. Dr. Hayden Smith. How's it going?
Good. It's been a while. It's been, I think, since the COVID vaccines came out that I was last on to kind of discuss some of the changes in the infectious disease landscape.
Yeah, I think, and that was the old show, the second shift, which I think has been was the most watched episode or listened to episode because people had a lot of curiosity at the time, and they shared it with friends and family because I think we aimed it, and I think we want to do that today too.
Yeah,
talk, so that anybody can share this. But
and I think it's unfortunate that I'm back because it probably means something else is going on in the infectious disease world. But I'm happy to be here. I'm glad you guys were able to invite me back to discuss.
Next month, Dr. Smith joins us for Marburg virus.
I hope not.
I hope not too.
That'd be terrible.
I was thinking he is more like the Jim Cantori of infectious disease. If he shows up here, something's going on.
That is
beautiful.
So
beautiful.
Yeah. So this episode's. Oh, sorry, Virtue.
Go ahead, Mike.
No, I was just gonna say this episode is really going to be focusing on a hot topic. For those of you that don't know, I am currently down in Texas. Been here for the last couple of years, and measles, or as we call them, freedom spots or something. I don't know. There's some name for it down here. It's making a pretty good comeback, and just not in Texas, right? It is everywhere. So Ritu thought it'd be a great idea. We get Hayden back on here and start talking about stuff.
Yeah, totally.
Let's but not everybody listened to our show 4 years ago.
For sure.
At that time, Hayden was one of our residents at Providence, Portland, and I think we worked together in the emergency department and started talking, and you told me you were going to go into infectious diseases at the time, and I said, well, are you interested in coming on? And you were like, yeah. And you were great. So, but you're up in Seattle now, right?
Yeah. So I followed through with that promise. I got continued my training at University of Washington. So I'm currently up here doing kind of like in my third year of fellowship, first year attending kind of hybrid setup that we do here at University of Washington. So I've been there doing clinical work, working at, the community hospital, Harborview. Oh, wow. Fun fact, Harborview is the hospital that Grey's Anatomy was based off of. So,
wow.
Yeah, I've been working there. It's not nearly as nice as Grey's Anatomy would have you put it, but fun little fact there. But yeah, I've been up here enjoying life, doing research. So, my claim to fame right now is working in diagnostics. So I'm pretty into developing molecular assays for various infections that we can talk about now or at a later time. But, with that said, clinician first and foremost, and have been, on bated breath with what's going to happen with this measles outbreak.
And so when you say you're working as attending, is that ID attending or
yeah,
cool?
Yep,
that's great. Yeah,
well, that's pretty good. Well, I think maybe a great place to start, and our good friend Tim Case sent some talking points that he thought would be great to cover, and I loved his first one, and that was kind of the SB and the S bar. I thought that was fantastic, right? So situation background. I was going to see if Ritu would cover it. Am I frozen?
Yeah, we're kind of missing you there.
Yeah. So situation, background, assessment, and recommendations.
Mm-hmm.
So yeah, I mean that is, that would be like the first question
Mm-hmm.
I would have is like, why are people talking about measles? I thought measles was gone.
Mm-hmm.
I mean, I've been practicing now for 30 years and had never seen measles until about 6 months ago.
Mm-hmm.
But I never thought I would see measles.
Yeah, so measles in the United States was basically eradicated for the longest time through the early 2000s, kind of up until the 2010s. Uh, Measles was essentially something that travelers would get. Either Americans would go to a measles endemic area and not be vaccinated, or people from a measles endemic area that don't have access to the vaccine would come here, and then measles we would take care of the measles case here in America. That's the majority of the cases that we would see. But with a lot of the vaccine hesitancy that's been promoted here in America, it's led to a much larger susceptible population, and so now we're starting to see outbreaks of measles locally in America, with person-to-person spread in America, and so that's leading to some of the events occurring in West Texas, and then I think there's some isolated cases in New York as well. So there's we can talk about some of the reasons why the outbreak is going on, but that's kind of why we're talking about it now. It's reaching headlines. There's ongoing discussions about efficacy and safety of the vaccine, and so we're here to discuss, kind of maybe essentially bring out what the research shows, so that we can be informed in our decisions.
Yeah, want to be as objective as we can. So there's been isolated cases of measles in Oregon too. Like I said, I saw one in it was an ethnic population that goes largely unvaccinated, and it was a child a playmate who had already tested positive for measles. So they'd already gotten the infectious disease test back, and then a couple days later, the kid came down with like a class, textbook, presentation, and I walked into the room and I walked out. I'm like, I think this child. I think I just saw measles, and I was like, I never thought I would see measles before.
Yeah.
And I called my ID specialist, and he's like, "Oh, yeah, no, it's measles."
Yeah.
And then I found out. Actually, went back and talked to them some more, and then they're like, "Oh, yeah, his playmate tested positive." I'm like, "Well, there you go." So I don't even think I even tested him. I just diagnosed him with measles.
Yeah.
On your
way. And that's something that you can do is, some of the signs of measles are so classic, you can just diagnose it clinically.
Yeah.
Well, we should. Oh, I was going to say we should talk a little bit about that. Is like, what exactly is measles? How does somebody get across? How does somebody get exposed to it? How do they spread it? I mean, I know that's kind of just threw everything against the wall there, but let's start.
Happy to talk about all those things. Measles is it's a respiratory virus, and so just to kind of ground people in what viruses are, they're essentially little packages of proteins that can invade your cells, but they need a cell, like a healthy human cell, in order to replicate, grow, and reproduce. And so measles is one of these viruses that gets into the human body, replicates, and essentially invades into the immune system, causing all sorts of damage and havoc. And then it presents as commonly it starts out kind of like a cold, but then you develop this classic measles rash that then your body has to fight and recover on its own. And so, I can go into like the 4 different stages and all that stuff, but that's kind of a bird's eye view overview of what measles is. The kind of the 4 main phases of measles is you have like an incubation period where you're asymptomatic. So you go from first contact with that playmate to then for about 6 to 12 days. You're typically not contagious at this point, but the virus. Yeah.
That's, I think, a big question. Like, if the person's not symptomatic, and you were exposed, how much is your risk?
Yeah, totally. So in this first phase, the incubation phase, you're not typically contagious, but you do have the virus in your blood. So it's what we call viremic. So if I were to take a sample of your blood, I can test it and see the virus there, but you're not contagious. The next stage is called the prodrome, and this is when you start having symptoms. This lasts for about 2 to 4 days, and you are contagious at this point. Typically, it's just like a common cold, upper respiratory symptoms. You can start getting fevers at this point, malaise. You can see some conjunctivitis at this point, but there's no rash. The key hallmark of the prodrome is what's called Koplik spots. So that's kind of a very unique kind of buzzword for measles. And it essentially is kind of like a white bumps in your mouth. So, I don't know why, anatomists and pathologists are so obsessed with food, but they describe things using food all the time, and they describe it as salt granules on kind of like a red base. And so if you look into your mouth, or you look into a patient's mouth and see that, measles should be, right at the top of your head, because it's a pretty classic finding.
Is it painful for them at all? Do they even realize that it's there?
I think it's mildly painful, but it's not like a herpes,
right?
Cold sore or anything like that. It's not like a divot like a cold sore was. I mean, we're talking really small little white dots in your mouth.
Salt granules.
Salt granules. Yeah, exactly.
Not kosher salt. Kind of the finer salt.
Yeah, sea salt, the good stuff. We only talk about the good stuff here.
All right, so that's the second phase. They get, and the conjunctivitis is another sort of classic kind of story that you get, is like, oh, I had a cold and then my eyes got real red. That was what my patient had been the story with that one. I don't think I saw Koplik spots on this child, actually.
Yeah, and you don't have to have Koplik spots to get measles, but if you have it, it's like, okay, yeah, clincher right there.
Yeah.
The other thing is where these show up. I think that's important to know, especially for the medical professionals. Typically it shows up on the top of the oropharynx in the back of the throat, but it also will show up on the cheeks. So you have to kind of do a really good sweep of the mouth to look for these little spots. Once you have those spots, though, pretty quick, you're going to develop the rash. And the rash in measles is a typical viral rash, a maculopapular rash, which just kind of means like a red rash that shows up that kids commonly get even when they get like colds. But this rash, stereotypically starts on the face, and then it kind of descends down the body. So you can watch it like almost in real time as the rash from, morning starts on the face. Afternoon, it's on the upper chest, maybe just getting onto the arms, and then by evening, it's on the torso. And you can see this rash develop over a fairly rapid period of time, and it's associated with the kid being really sick. I mean, a kid or adult, but typically this is a childhood disease. But the kid will be really sick. They'll have a fever, they'll be really uncomfortable. They will likely have a cough. This is primarily a pulmonary infection. And that'll last for about 48 hours. During this time, there isn't much for a parent to do per se. I mean, you can give Tylenol for the fever. You can give them some nice chicken noodle soup to feel better. But there aren't too many, medicines or interventions that we give for measles infection. You kind of have to write it out. After that 48 hours, and I should say this is when the lymphadenopathy, or kind of those lymph nodes, are really prominent. Last about 48 hours, and the kids should start to get better at that point. And then that kind of brings us to the last phase, phase 4, which is the recovery phase. And oh, good, yeah, perfect. That's a really good picture of
apparently the CDC still does things. So this is from their website.
Yeah, I love that. That's classic. It is more prominent on people with fairer skin. Darker skin, it can be harder to see, but it is noticeable. The recovery phase lasts about 1 to 2 weeks, and it's usually highlighted by just a lingering cough. There's important things to talk about your immune system, complications of measles that we can get into in a little bit. But as far as typical course of disease, this is what happens. And if you're using like the Texas data for what's going on in the current outbreak, it's about 2/3 of patients are going to follow this classic course for measles.
Yeah. So altogether then from like, well, we won't count incubation, but like from first symptoms to resolution in most cases, sounds like 2 to 3 weeks.
Yeah. Yep.
And are you contagious even in the last phase?
Yeah, the recovery phase.
Recovery phase, yeah.
So the ability to transmit it, the contagiousness really drops off after the rash starts to develop. Because what's happening in your body is at that point, you're now making antibodies to the measles virus. And so you're containing it, you're isolating it, and you're not shedding the virus. And so in the recovery phase, your contagiousness drops off pretty rapidly. Most contagious in the prodrome and the rash phase.
So you're going to be pretty contagious when you think you have a cold.
Yeah. Mm-hmm.
Okay.
Yep.
All right.
Yeah.
Well, I mean, that doesn't sound too bad. I mean, one of the arguments that we hear is, oh, kids used to get measles all the time, and it was just a regular part of growing up, which, I mean, I'm almost 60 now because I'm old. And I don't I got an MMR when I was born, I was vaccinated. So, certainly don't remember. And I do remember the days of chickenpox parties actually.
Yeah.
Which, that doesn't sound terrible. What's the big deal?
Mm-hmm. Yeah. So the measles infection can be benign, like I discussed. But if we're looking at some hard data, right? I like hard data.
So do we.
Look at the outbreak that's going on in West Texas right now. 1/3 of the the people that get the measles virus are going to the hospital. And so, that is not a small number. 1 in 3 chance of going to the hospital. And these are not kids that have a underlying medical condition. It's not like they are, immunocompromised or anything. These are normal, healthy kids going to the hospital. So, 1 in 3 chance going to the hospital is not great. But on top of that, why do they go to the hospital? Why does it get so severe? Is I think the main question that people have. What is the harm in the measles infection? And it really comes down to how measles works and how measles destroys your immune system. So viruses, although they're these kind of just like packages of proteins, they're really, really good at doing what they do. And they've developed a way to essentially invade into your immune system and then spread inside of your immune system using various cells as Trojan horses. So they get into, I think it's the dendritic cells. Immunologists out there. They get into those cells, which then essentially taxis them to your lymph nodes. And then they are there to just go and invade all of the immune cells that are in your lymph nodes, which is why you get this lymphadenopathy.
Yeah.
And so it just picks them off one by one. And we're talking, billions of viruses in one lymph node, right? Huge numbers.
Yeah.
And it just destroys your immune system. So, there's a study done in 2019 by Mina et al. In 2019 in Harvard. And essentially they said, okay, we know that this happens in theory. Can we show that it happens on the larger scale? And what they showed is that in natural course of measles infection, you have about 11 to 77% destruction of the antibody repertoire. So So that's essentially the diversity, the number of proteins in your body is destroyed by 11 to 77% with a natural course of measles infection. And that is 2 months after the infection. So it comes in, hits hard, and then you have this prolonged course of like a poor immune system that you're living with, and it has to recover.
So do they find, oh, sorry, Hayden, do they find that these kids or adults or whoever gets it in that 2 to 3 month period are being readmitted with pneumonias or just any other kind of medical issues that they get?
Cellulitis, all the different kind of infectious things you can get.
Yep, you're absolutely right. So the number one cause of death in measles is what's called measles associated infections. They're called secondary infections. And these are infections that you wouldn't normally get had you not had measles. And I think that's an important thing to highlight, because a lot of people that don't quite understand what's going on with the measles virus and how it's destroying your immune system inappropriately assume that the pneumonia they get after measles is unrelated. But that's just not true. We're talking infections like staph infections, bacterial infections, pneumonia, mycoplasma, things that cause pneumonia after measles infection that they would not have gotten otherwise. And so you get this terrible infection afterward. Your immune system is crippled. Your lung cells are already ruined from the measles infection. So it's just a perfect petri dish for these other bacteria and germs to come in, cause a rip-roaring infection really fast. And unfortunately, that's what leads to death in measles. It's not the measles virus that kills you, granted, but it is measles that caused the person to get sick.
And then how does this immunity bounce back at some point, or do you have to sort of almost like rebuild it, like get exposed to stuff again and hope you don't get sick and that sort of stuff?
Good question. I don't have a strong answer to that. That would be kind of a long-term thing. I can tell you what's been done in other situations where this has been looked at, most notably COVID, but there's a lot of testing like this has been done in COVID, because COVID does a similar thing. And it does take time to recover your immune system. Most of your antibody repertoire does come back, but you do lose some diversity, because if you had only a handful of cells that had a memory of that flu in 1987, then you're not going to get that back after it was destroyed. With that said, most of your immune system does come back, a couple of months after the measles infection.
So does that include like previous immunizations that you've had? So let's say you're 3 years old, you're up to date to wherever you need to be with your immunizations. You come down with measles, you get wiped out. What is your immunization status effectively after that? Does that all come back as well?
Yeah, it typically does. I mean, when you're talking about a vaccine, the immune response is so robust that you just have layers upon layers upon layers of robustness, or just it's been replicated so many times that it's going to come back. You don't have to worry about that. But with that said, in that short period of time when you've been immediately hit with the measles infection, you are susceptible to things like vaccine preventable diseases, like influenza or whatever. You kind of bring up something that I also looked into, and it was the question of what happens to our immune system after we get the MMR vaccine. Right? I think it's we need to directly correlate these two things, because if the MMR vaccine does the same thing to our immune system, well, maybe there is some validity to this whole MMR vaccine dangerousness thing. And so a really, really good study was done also in 2019 by Zimmerman, where they looked at antibody levels of vaccines like the hepatitis vaccine, and compared those levels before and after the MMR vaccine. Because after measles, you'll see a decrease in those, or they will go away. But in this controlled, this really well thought out controlled study, they said, okay, let me look at this. I mean, there's a whole panel of known antibodies, gave them the MMR vaccine, and they did not see any change in the antibody levels with the vaccine. When you do it with, taking these two studies and interpreting them together, what I can say is, with measles natural course of infection, you get this, you wipe out your immune system. But with the MMR vaccine, you don't have that effect. Right. We're talking, attenuated viruses that don't cause this, Trojan horse effect that then leads to, this huge immune response. It's much more muted. And the degree of the infection is the outward expression of that effect, right? You don't get a rash when you have the vaccine. You don't have the high spiking fevers. You don't have this, weeks of cough. You don't get that with the vaccine. And so you don't have a similar dramatic effect in your immune system as well.
Yeah. So one of the things that one of my other medical director colleagues brought up when we were talking about this and what to talk about is this neurodegenerative disease that people can get like 6-10 years later, which I had actually forgotten about because med school was 30 something years ago. But and to be honest, like the part of my brain that studied measles studied it for the test,
flushed it,
said never going to have to worry about this again, and it went away.
I did the same thing. But I then went into infectious disease. I'd all relearn it all, but yeah.
So what is this like 6 years after you have the measles, you can like get this brain thing?
Yeah. So there's actually 3 neurologic conditions you can get from measles. I'll talk about that one last because that's the most interesting one. But the first 2 actually occurred during the active measles infection.
Okay.
So it's like, an active, measles syndrome that we get. And so the first one is just run-of-the-mill encephalopathy, confusion, wasting, and, varying levels of, consciousness, things like that. That is going to be your encephalopathy. And that occurs in about 1 to 1,000 cases of measles. And so, this is a severe complication of measles that can occur, and it's from the actual measles virus. And so you'll see a meningitis from measles that can occur.
So there's virus in the
central nervous system,
in the CSF.
Correct.
Okay.
The next one is called ADEM, or acute disseminated encephalomyelitis. So ADEM, it's a big word.
Say that one 3 times.
That's
I know, right?
No fun though.
Breaking that one down, essentially what happens is the virus causes what's called demyelination, which is destroying destroying the myelin sheath of the neurons in your body. And so think of something like MS, multiple sclerosis.
Yep.
It's it's a similar process in theory, obviously very different cause, right? It's the measles virus that's causing it. And what happens is the measles virus causes this neurologic demyelination, causing a lot of neurologic symptoms. And that occurs in about 1 in 1,000 cases of measles infection as well. So 1 in 1,000 is the encephalitis. 1 in 1,000 is this ADEM demyelinating process.
Yeah, I was just gonna say, how I've described demyelination processes like to patients and things is if you think of your nervous system as long wires, and the nerve cells have like a body, and then they have a long wire that connects them to the next cell. This is the insulation that is around the long wire part. And if you have like a live wire and you take off the insulation and try to send electrical current across it, it'll just jump out, right? And won't work.
Yeah.
And so basically you're removing the insulation around this long wire, and then you're basically making that wire non-functional.
Yeah. And then that results in like weird movements, and you
Right.
can't touch your finger to your nose and stuff like that.
Yeah.
So the demyelinating process, the encephalitis, those actually go away over time. They're very dramatic. They're very scary when they do happen, but they typically do resolve with the measles infection. You're going to have to deal with it for a couple more weeks afterwards, but they usually do resolve. I mean, there are cases of the ADEM having long-term consequences that persist through life, but for the most part, people or kids recover from that.
The
one that you were talking about.
Is there treatment? Like,
yeah.
I mean, can we? Yeah. Is there anything? I mean, my sense is as a clinician, I'm going to primarily do supportive care all the way across the board for measles. But certainly, if they get some of these specific kind of complications, is there any kind of treatment? I don't know. Can you give like IVIG or something?
Yeah. So there's various different treatments. Most of it is supportive care. I mean, there is no silver bullet treatment that we have for measles. In severe cases, you can do a couple of things. Vitamin A is one of them that has been shown to have some improved mortality. The data on that is it's not super solid, but there has been that shown in the literature. Ribavirin is an antiviral that can be given that is known to be effective against the measles virus. And we usually give it for, patients that have this encephalitis picture or have the pneumonia and it's just not getting better. And then IVIG can be used in unvaccinated pregnant mothers is typically where that's used. There's no real role for IVIG to be used as like a, post-exposure treatment in unvaccinated people. It just hasn't shown to work. But, there's kind of room for clinician discussion when it comes to the IVIG part. The main two treatments are going to be vitamin A, ribavirin, and then IVIG in pregnant persons.
Before we get to the third one, a question did pop back. I mean, so a patient gets measles, their immune system gets kind of amnestic, and then they get pneumonia. I mean, we have antibiotics, right? I mean, we should be able to fix that, right?
Yeah, so if they get pneumonia, then there's different treatments that we can do. But then you're treating a secondary pneumonia infection.
Right.
But those are typically very difficult infections to treat because you're starting from square, zero, right? You've already destroyed your lungs. You've already destroyed your immune system. And so it makes it really hard to treat. This is kind of a little bit of a side note, but the more I treat infections, the more I get myself involved with these complicated cases, the more I realize that us doctors don't really do too much.
Right.
We kind of tamp down things. We, make it easier for the body to do its job, but ultimately it's the body that does the healing. Yes, I have some powerful antibiotics that can kill a lot of bacteria, but at some point there's limits as to what these antibiotics can do. And the body has to be the one to step up and heal itself. Otherwise, I could bathe you in antibiotics and it's not going to get you better.
Yeah, I think I run into that where my patients don't really understand. The way I describe it is like it's a battle, right? It's a battle between your body's immune system and this invading bacteria. And in fact, the majority of times if we didn't treat with antibiotics, your body would win the battle, right? But
yeah.
I mean, 80% or 90% of the time, if people are like, oh, I didn't realize that, because they're always like, they come to me like, I have to have antibiotics. Well, you really don't for this.
Yeah.
Now that you're an adult, but okay, whatever. But so that's how I explain it. I'm like, you have this battle going on, and then what the antibiotic does, it comes in and provides support to your body, but it's really your body's immune system that's still doing the lion's share of the work.
I mean, running with your analogy, I think of antibiotics as just the airstrike, right?
Yeah.
But you still need the army to go in and take the land, and that's what your immune system does.
Yeah.
So we can call them the airstrike, but we can't necessarily, conquer nations, if you will.
Yeah. And then, the third one now, this subacute sclerosing panencephalitis.
So subacute sclerosing panencephalitis, SSPE, is a long word to describe the neurologic syndrome that happens years after a measles infection. And so what is happening? So I'll be honest, the exact pathophysiology, the exact process that's going on here isn't super well understood, but it is known to be directly associated with measles and the measles virus. The current theory is that there's ongoing low-level replicating virus in your nerves that just persists for years, and then something happens, it flips on, and it causes this SSPE process, but no one actually knows. What actually happens, though, is you have slow progressive destruction of your nerves in your central nervous system, so like your spinal cord and your brain. And so it's terribly debilitating, and really not good to have. And it's directly related to a measles infection. And so I looked into this a little bit more because my next question was, who gets this? Why do you get it? And stuff like that. And the reality is there's no real good correlation as to who gets it. You just have to have natural measles infection. So the attenuated virus you get in the vaccine does not cause this, but full measles infection does. And it kind of makes sense, right? Because the current theory is that it's an ongoing, really robust, strong virus that continuously replicates in neural cells. But the attenuated, weakened, wimpy virus that's in the vaccine doesn't have the capability of doing that. And so, but that's good in theory. Let's look at the data, right? So the U.S. surveillance, the CDC U.S. surveillance data has shown and tracked this SSPE phenomenon. And they did it, and they've doing this since a long time, I think since around World War II, but I didn't look that far back. Yeah, it's been a while. And what they showed, I want to make sure I say this right. So the rates of SSPE in America before the MMR vaccine were about 8.5 cases per million cases of measles. So 8.5 of SSPE, 8.5 million of cases. So it's really rare. Once the MMR vaccine was widely distributed in 1971 or something like that. Don't quote me on that. I think that's wrong. The drop off was profound. It went from 8.5 per million to 0.06 per million. So we're talking a huge drop off in an already rare condition that occurred purely because of the intervention of the vaccine. And so that tells me that, the vaccine really is not causing this SSPE. If the vaccine did have any contribution, then I expect that rate to stay the same or go up.
Yeah.
But the fact that it dropped off so much means that the vaccine's not causing it. This is a function of natural measles disease. And so, yeah. And so, it's important to be vaccinated, but also understanding this potential late side effect of measles infection.
I think since you brought it up, back in the 70s, I was born in 72, and I had my course as usual, and I don't even remember what the frequency is, of what the series of MMRs is, or if it's just once. I honestly have no idea. In 2001, I think I was starting paramedic school, and they checked to see if I they were checking to see if I had chicken pox. And they said, "Oh, no, you must have been exposed sometime," because I don't remember ever getting chicken pox.
Yeah.
But we couldn't figure out, I couldn't find my immunization record or something like that. And they suggested I get an MMR. So I guess the question kind of is how good does it last forever? Should I don't really hear of boosters very often. I mean, I ended up getting one apparently. But what's the story with that?
Yeah, great.
Can I build on that? I mean, I think when we talk, I think one of the most common questions I get from clinicians, especially frontline, emergency physicians, because we talked about it amongst our emergency medicine group, as well as my EMS practitioners, is do I need to get a booster? Do I need to get another MMR shot? Assuming I'm willing to do that.
Yeah, great. Those are great questions. So I hear like one of, general population who gets boosters. Kind of another question. I'm at higher risk of getting measles. How do I walk through that? Think through that process. So for the first one, general population, who do I get a booster? And the short answer to that is no. So measles is one of these infections that one of these viruses that once you are exposed to it, you get lifelong immunity to it. And this has been shown time and time again with multiple studies that have confirmed that once you get either the infection or the vaccine, you have what's called durable immunity, and it lasts for your lifetime. And so, the measles vaccine or the measles virus doesn't mutate like the flu does or like COVID. And so, the virus just stays the same. It doesn't change. And so we don't need these boosters because there's no new strains or anything like that. So it's good. If you look at the guidelines, if you were born before 1957, you do not need a vaccine, full stop. It's assumed that everyone before 1957 was exposed to measles. It was just so prevalent. Everyone saw it. Everyone's immune system was touched by measles at one way or another. You don't have to worry about getting a measles. You don't have to worry about getting a measles vaccine or booster for that matter. After that, we do recommend getting the vaccine. Measles cases dropped soon after that. I think that's about when the first version of the MMR vaccine was brought into production, and so so it's unknown if you were touched by the measles virus before then. So we do recommend getting the vaccine. Most people nowadays have gotten it. Unless you have a strong personal conviction to not get it. So does that kind of answer your question, Mike?
Yeah, absolutely. Yeah.
So then kind of going to the other side, okay, I'm a healthcare professional. I'm a high risk. Maybe I work in West Texas right now. Should I get a booster, right? And so what we recommend is that each and every healthcare professional gets tested for the antibodies to measles. If you have the antibodies to measles, you have immunity regardless of how you got that immunity. And so every healthcare professional, we do say get it. The vaccine has like an 87% seroconversion rate, so it is not perfect, right? And so we do want to check that and make sure that it is that you have seroconverted if you are in the healthcare profession. I commonly will check. I occasionally, I shouldn't say commonly, I occasionally will check it in like my HIV patients as well, if they seem to be at increased risk. So other immunocompromising conditions you could consider getting checked for your measles serology. Before getting a transplant, we will check for measles serology, make sure that you have that immunity, because you can't, when you're immunosuppressed, you can't, it's harder to develop immunity. You can't get attenuated vaccines, things like that. But I'm rambling.
It's all good.
The main takeaway is, if you're in the healthcare profession, it is reasonable to check your serologies. But whether you get a booster is purely dependent on what your serology show.
Yeah. So I think when I started, I can't remember if it was med school, residency, or a clinical job somewhere. Mm-hmm. I think I got rubella titers. And they said, "Oh, your rubella titer is negative." So, and I said, "Well, I had an MMR." They're like, "Yeah, but the titer's negative, so just go ahead and we'll give you another MMR." So I think I got another MMR like 20 years ago.
Yeah. Mm-hmm. Yeah.
Kind of like Mike. Yeah. So would you still, if I got an MMR, sometime later in this, would you still recommend getting the measles titer done, or okay, I got vaccinated, I'm good to go?
If you got the, I always err on the side of checking, right? If you have concern, might as well check. It's not going to hurt. If you're going to someplace that has high endemic measles, highly endemic measles,
like Texas,
just check. Well, I wouldn't qualify Texas as highly endemic yet, but someplace like
West Texas,
East Africa maybe.
Don't confuse West Texas with the city of West Texas.
I was not aware of that difference.
Yeah. West Texas is literally Western Texas. West Texas is a area north of Austin and up towards Dallas.
And it's not in West Texas.
It's not in West. Yeah.
Geography, strong point there.
Yeah. So let's switch gears a little bit and talk about PPE.
Yeah.
We got EMTs, paramedics, nurses, whatever, going out on calls. Occasionally physicians. We'll leave out MD 59 here. But is there anything, above and beyond what we were doing for COVID? Just an N95 mask? Is that overkill? Surgical mask? What do you think about that?
Yeah, great question. I was going to bring it up if you hadn't. So the short answer is airborne precautions, right? If you suspect measles, airborne precautions. You just put them in airborne precautions until you can figure it out. The transmissibility of measles is so high that you don't want to miss it, right? It's the number we use to kind of gauge how transmissible an infection is called the R naught, and in measles it's 12 to 18. Ooh. So what that means is, for every one case of measles, on average, 12 to 18 other people could get it.
Oh, wow.
So if you have a population of people that are completely unvaccinated to measles, one case of measles goes into a room, 12 to 18 people come out with measles.
And then that just continues on.
Yeah, it's crazy.
It's like that commercial, and so on. And so
yeah. Butterfly effect, but on steroids.
Yeah.
So the other way to look at it is, what is my individual chance of getting it? And it's about 90%. You have a light conversation with someone with measles, you have about a 90% chance of getting measles from that person. So highly, highly contagious. So that's why we take excess precautions. Airborne precautions is the appropriate precautions, because it can just be transmitted through air droplets. And And so, yeah, that's what we do. Obviously, healthcare workers, if you're in a high risk of getting exposed, you want to be vaccinated and confirm that vaccination. The other thing that I, would give a soft recommendation for, technically it's not required, but I would recommend avoiding pregnant persons, take care of anyone that may be in contact with someone with measles, just because in the rare chance that they aren't appropriately protected, there are, side effects to the mother and baby in measles. So that would kind of be the other thing to think about.
I've got two questions I'd love to go back in time from earlier in our conversation. So the first one is, you mentioned the 1 in 3 chance of ending up in the hospital.
Yeah.
The current situation in West Texas.
Yeah. Yep.
Now, so what does that mean? That like just went to the ED, got admitted, ended up in the ICU? Like, so what's the?
Yeah, good question.
Yeah.
So Texas just updated all their measles data yesterday. So I was kind of digging into that yesterday. But what I'm talking about is hospitalization. So admitted to the hospital from measles. And I misquoted you. It's 17%, not 33%.
Okay.
It kind of changes.
Sure.
So it's hard to say.
Yeah.
But if you look at the 2024 data, it was 40% hospitalization rate.
Oh.
Right now, it's a 17% hospitalization rate. So that's where we're at right now. Yeah. But that is people getting admitted to the hospital. They have complications. They have either a pneumonia, they have encephalitis, something from measles that's warranting them being in the hospital.
Yeah. Well, the second question I had was, again, even going back a little bit further, and I think we mentioned it in the first 5 minutes of the podcast, was, the idea of vaccine hesitancy. I can't put my finger on. You probably have better data than just my sort of gut feeling, but like, when did that really start to become a thing? Because I mean, even so, my oldest is 30. And I don't really remember. So he was born in 94. I don't remember that being a really like hot, controversial topic. So at what point did we sort of have this shift in timeline and this phenomenon kind of started?
Yeah. And this is, this is something that I think it's important for us as clinicians to understand so that we can help better explain some of the hesitancy and understand it, because ultimately, from what I've experienced, vaccine hesitancy is parents trying to do what they think is best for their kids, right? They don't want to expose their kids to unnecessary toxins, unnecessary, infections. It's scary to hear a live attenuated virus. Why would I give my kid a virus?
Live virus.
Right. Yeah. I mean, I understand it, and I think it comes from a good place, right? From what I have been able to, in my discussions with patients and family that have hesitancy, it kind of boils down to a couple of central ideas. And the first is a perceived risk of harm caused by any vaccine, MMR, COVID, or otherwise. And then a second one is a no perceived benefit of the vaccine over natural disease. And I think that the flu vaccine is an example of this, the second line of thinking. It's like, well, I'm young and healthy. Like, why do I need to get the flu vaccine? I'll just go through, if I get the flu, I'll be just fine, right? But that definitely applies here to measles as well. I mean, you lived through a measles infection, surely my kids could do that as well. And so
everybody got the measles in the 1950s. So America is still here. So, shouldn't we just let the natural immunity of our children be, rather than putting these chemicals in our body?
Yeah, exactly. So I think those are kind of the two main concerns that people have with vaccine hesitancy. And, I can totally understand that. I'm a father of 4 myself. Like, you don't want your little kids to be getting all these shots. You
Yeah.
know, it's a lot. It's a lot, and I understand the reasons for the hesitancy, but kind of as we already discussed, especially with the second point, you know, and measles in particular, there's a real harm to be had with a measles infection.
Yeah.
I mean, we're talking a 17 to 40% chance of going to the hospital from an infection. I mean, that's astronomical, right?
Yeah. Well, it'd be crazy to like die 10 years later from brain swelling.
Yeah, exactly. And then you know, 10 years later, you're on this risk of getting this terrible progressive disease that, oh, by the way, doesn't have any treatment, right? Like,
Yeah.
So as you know, as EMS sort of wanders more into the homes in a non-emergency sort of fashion, right? Community health, things like that, prevention. You know, do you have any tips on how we would communicate this with people? Because I just feel like it would be a fine line, right? You mean, you don't, I mean, you want to educate without demeaning, and you know, I mean, I personally feel like I could do that, but are there any tips or suggestions or just ways to communicate with folks to sort of get the point across without, you know, without, I don't want to say offending them, but you know, just so the point isn't lost, right? That's the essence.
Yeah. Unfortunately, there's no silver bullet argument that I can just say, throw them this information and it will stick. You know, my experience is that, you know, if I were to give you one tip, it would be ask questions.
Yeah.
Don't overwhelm people with facts. It just bounces off their heads. Don't overwhelm people with, you know, your understanding. You can't come from a place of superiority. Like, ask questions, right? And then once you understand how they are making their decision, because their decision is informed, they're using their knowledge base to understand it. Then you can start helping them understand what you know, right?
Yeah.
And it's kind of a back and forth. I understand what you know, you understand what I know, and then everyone can make a decision based upon what they know.
Yeah. I mean, I wouldn't anticipate we're changing any minds, you know, in these short, you know, experiences that we're going to have with these folks. But, you know, just those are the kind of things that I think about is like, how can I just plant the seed, you know, to have that, you know, conversation with other folks or whatever.
I think there's a couple things too. I think, you know, first of all, the question about vaccine hesitancy, you know, there's always been this sort of this sort of small movement of folks that have kind of pushed back, whether it's distrust of government, distrust of the medical, but it didn't, you know, it really was the Wakefield paper that kind of drove that. And I just kind of looked up, but you know, that was published in 1998. And that was the thing where stuff took off. And the Wakefield paper, for people who don't remember, because it's gotten a lot of press, was the paper that supposedly stated that there was an association between vaccination and autism. That was the thing that drove a lot of kind of made it more mainstream. I think people who were naturally going to be a little bit more worried or scared or whatever were then like bombarded with this idea that, oh, I could give my kid autism. But you know, autism has been on the rise, but it turns out that when you look for things, the number of them you find increase. And I think that it's been pretty soundly debunked, that paper. The Lancet that published the paper,
didn't they retract that?
They retract it. But what's really interesting is, like, when we talked about the COVID vaccination stuff, people were like, oh, this was hurried, it wasn't studied well enough. And you know, we talked about the fact that because there were so many volunteers, the number of patients that the mRNA vaccine was studied upon was actually the same as any other vaccination trial, or if not greater. The Wakefield paper was 12 patients.
Yeah.
And there were 12 patients, and then they decided that it was linked to autism falsely. And so, I think that's kind of, I think things really took off
Yeah.
after that.
Yeah. I mean, I have a whole timeline here that I kind of wrote down because I think you're right. When in order to understand how someone thinks, you have to understand what's happened in the past.
Yeah.
And that Wakefield paper really was the start of the movement. And after that, it kind of entered the zeitgeist of this whole anti-vaccine culture. And
it's a good podcast where you use the word zeitgeist.
Yeah. And so, yes, it was, it was a flawed study. It's easy for us to kind of talk about that, but the reality is it kind of entered this culture. And so, overwhelming evidence is needed to sort of show that. The other seminal event in anti-vaccine discourse is what's called the Hanna-Poling ruling. Have you guys heard about this before?
I haven't.
Yeah, so this is really, really important for, I think, medical professionals to know about, is because it's a case in 2008 that was then ruled in 2010 and really kind of kicked off this current rise in anti-measles or anti-MMR sentiment, right? And so Hanna-Poling was a child who was thought to be otherwise healthy, got MMR vaccine among other vaccines, and she developed kind of this fever syndrome that then led to neurologic changes thereafter, later diagnosed as autism. And so this was presented to the court case, the Poling family against I forget the drug company, but it was against the drug company that creates the MMR vaccine. Litigated for a long time, and finally deemed to be the drug company deemed to be responsible for this case of autism in Hanna-Poling, and they were awarded $1.5 million. And so, it is a case of where there is this plausible causality from an MMR vaccine causing autism. And so it's really important to anti-vaccine people to understand that this has happened in the past. Like there's this litigation. And so when I looked into it deeper, though, look beyond just the headlines, what was discovered in this case was that Hanna-Poling was not your typical child. She had a mitochondrial enzyme deficiency, which, if you know anything about these deficiencies, is they do cause neurological dysfunction, including autism. And so, and then not on top of that, she's had these fever episodes throughout her young life. She's had recurrent ear infections, recurrent fevers, recurrent pneumonias from this mitochondrial dysfunction. And so, these things were found during exploration, but then were ultimately still thought not to be important enough confounders, and the jury decided to litigate the drug company, not litigate, but award the what is the legal term I'm trying to say? Sue. They sued them.
Liability.
Thank you. So that's really important. But in response to the Hanna-Poling decision, the scientific community then came out and came up with a huge body of evidence showing that this is not an actual correlation. So the paper that I always point people to when they ask about the science behind autism and the MMR vaccine is a paper by Dr. Taylor in 2014, where it was a meta-analysis, so the highest level of research we can do, meta-analysis of 1,256,407 children that were previously unvaccinated with the MMR vaccine, in contrast to the 12 in the 1998 Lancet paper. So over 1 million children were included in this meta-analysis, and it showed definitively that there was no correlation between MMR vaccine and autism. This has still been reassessed over and over and over again since that 2014, seminal paper that further confirms that there's no correlation between MMR vaccine and autism. So, I think the evidence is pretty overwhelming, but with that said, I do understand the sentiment that we want to figure out what's causing autism. And I think, whenever I have this discussion with people, that is the core value that they're discussing. Right? I want to know why my kid has autism. I want to know why autism rates are on the rise. And as a medical community, I think we need to be more willing to say, I don't know, right? There may be something causing these increasing rates. We can chalk it up to, testing bias, but at the same time, maybe there is something going on. So, I think it's okay to ask the question of what's causing these increasing autism rates. But in that same breath, I would say it's not vaccines, right? Vaccines have been shown overwhelmingly that they are not causing autism. I think it's good to explore maybe why the rates are rising, but let's not question the science that's come before the question.
Yeah, I think the other thing I just wanted to add to Mike's question about like, how do you have this conversation is there's this thing that Ted Lasso says that he misattributes to Walt
It's not an EMS show unless we're quoting Ted Lasso.
That's not true. It's not an EMS show unless I curse, and I haven't yet. But one of my favorite scenes in the whole series is when he's playing the darts with Rupert, and Rupert doesn't realize that he played darts like his whole growing up, right? Mm-hmm. And this be curious and not judgmental, mm-hmm. which is not a Walt Whitman quote, even though he says it was. I just found that out. But when I talk to all our new hires at most of our agencies about my expectations from them as a paramedic or an EMT, and that's one of the things I talk about is don't judge people, because one, it's not your job. It's not your job is to take care of people and not judge them. So don't judge people. And it turns out that from like a mental health perspective, if you don't judge people and you just accept people for who they are, then you don't drive yourself crazy. I think it helps your own mental health to do that. Yeah. But I think, be curious, ask, I'm just curious why. I don't feel like I've ever really convinced somebody to get a vaccine. I have had interesting questions or interesting conversations where people were like, well, I don't trust Western medicine. I don't, and then I'm like, well, I'm just asking curiously, why did you come see me then? And they're like, oh, because I want you to give me antibiotics and make me feel better. I'm like, wait a minute. But I certainly am not above challenging false facts. Mm-hmm. When somebody says, well, there's research that shows that autism is caused by it, I will push back. I will say that, that was based on a single paper that has since been retracted. And there have been numerous papers that show that there is no linkage whatsoever. And so, while I understand that that's what you have been led to believe, that is not, I'll push back on facts. And I'm an emergency doctor, so I can't choose my patient population. And, I know some pediatricians who won't take on patients' families if they're not willing to vaccinate. And I actually, I think that's their choice as a practice. Certainly the argument that I don't want unvaccinated people sitting in my waiting room with patients who are immunosuppressed is not an unreasonable one. But yeah, I mean, people make bad decisions all the time. People are allowed to make bad decisions. People who are otherwise rational do really dumb things, and you just gotta kind of ask the question and teach, because fundamentally, a physician or a healthcare giver is a teacher, and teach and then manage expectations. If this is the measles, I don't have anything I can give you.
Yeah.
But it's just too much brain space and heart space to get judgy about it.
Yeah, totally. I mean, we see things come in through the door all the time, and it's like, I'm here to help you. Like, I'm not trying to be your enemy. And I let my patients know that, like, when when conflict comes up around vaccines or whatever, most commonly it's COVID, but even with the MMR vaccine, like, I let them know I'm there to help. I'm there to treat, and I'm here to give it information if you want it. And so that is kind of the role I try and take, and the approach that I have. I don't want to ever force people to do anything, but I do want to let them be informed.
Yeah, that's awesome. Well, we're at about 1 hour and 10 minutes. I think it was a great discussion. Appreciate you coming back on with us.
Of course, always a pleasure.
Yeah. Hopefully we can have you on and talk about something besides the next great infectious disease problem we're having.
Yeah.
I'll tell you one thing that I have been thinking about for years, and I'm not sure where it came from, but I would love to have you come back and talk about HIV. Like, I mean, I would love to get an update of sort of where we were, where we are, where we're heading, all that kind of stuff. I just find that fascinating. So
yeah, that sounds like a date.
Yeah, sounds good.
Yeah, let's do it. All right, cool. Well, hey, everybody, thanks for joining us on the special episode of the EMS Show. On behalf of Dr. Hayden Smith, Dr. Ratusani, this is Mike Verkest. And again, you've been watching the EMS Show. We appreciate you listening, and we'll talk to you soon.
Hey, thanks for listening to the EMS Show. Let's continue this conversation. What do you say? Check out the official Facebook page and Twitter feed. The EMS Show is a Firedog production.